Hello, my name is Lawrence Tannenbaum, and I'm pleased to have this opportunity to present this talk on AI and spine imaging. We'll talk a little bit about what is AI, and then we'll spend some time talking about impact in the spine and some of the bullet lists you've seen there. So what is AI? Basically, it's a branch of computer science that allows machines to do things that are normally associated with human intelligence, such as reasoning, learning, and self-improvement. Essentially, a technology that is enabling machines to sense, eventually comprehend, act, and learn as they go along. And as we probably all know at this point, AI is all around us in a number of different areas. We see it every day. And in terms of healthcare, there's an awful lot of interest. You can see there's really a large amount of investment that continues to escalate. As you can see, Siemens, GE, and Philips, the big OEMs, are amongst the largest patent applicants in the AI space. Now, at this point, we know that AI is capable of a lot of different things. AI is responsible for autonomous driving through computer vision. It is well known for defeating experts in things like chess and Go. And frankly, while to a lay observer, these seem like amazing tasks, they're actually some of the lowest hanging fruit for machine learning tools to do is to beat experts, figure the way to beat experts in a machine. We all know the plague of online advertising, where everywhere you search, it follows you around. This is an AI application. To some folks, AI represents the new electricity. You can see that now, in terms of image recognition, computers are already outperforming humans, and they're actually already outperforming humans on speech recognition, which is pretty impressive. But there are still limitations. Robots look pretty impressive until you give them a difficult challenge and they fall down. Driverless cars work really well until they don't. And in terms of reading and comprehending, AI tools, natural language processing, understanding tools are limited to the 6th grade reading level at the present time. And really where AI falls down is where you run into context. And this is a great example here. You can see there's something odd about this. A human sees this right away. There's something weird about this picture, but the computer doesn't. It sees a tree, it sees a rock, it sees dirt. It doesn't really understand that there's a problem with that rock levitating in space, and it certainly doesn't recognize that that is actually an upside down picture of a rock in the water and everything else is reflection. Perhaps another apt example is this one. It recognizes a bicycle, it recognizes the grass, it recognizes the sky, but doesn't understand why the wheels are touching the sky rather than the grass. Here's another lovely example where you see a duck. It knows it's a duck, it knows it's a TV, it knows it's a barn, but doesn't understand that it's odd for the duck to be watching TV, particularly network TV on top of a barn. Now, AI does some remarkable tasks right now. It can do a wonderful job differentiating, say, chocolate chip ice cream from Dalmatian, which is pretty impressive. But, sometimes it makes major blunders, such as calling a blueberry muffin a Chihuahua. And while that one's not too particularly important, these types of accidents are much more important and give you the illustration why in both of these cases, human intervention, human involvement is still critical to success and really wouldn't work very well without it. Human involvement in AI is seen throughout the world, particularly when context matters. It's there at Facebook and Google and Twitter. At all the financial institutions, there are humans sitting next to the AI systems. And even in China, where the computers do a wonderful job censoring, human sensors are also involved, largely to do context. And frankly, another thing about AI and radiology is that it's really important that the data scientists work with the domain experts and vice versa to avoid problems like this, where this poster was all over Los Angeles, hanging on poles and banners going everywhere. And no one pointed out to them the brain was in backwards. So in general, with that bit of a preamble, you should understand that hard problems, being an expert at Go, looking through reams of data to find a pattern, are really easy for AI. The easy things that we think are easy are actually very hard for an AI, recognizing your mother walking across a room, picking up a pencil, and that really is a good sense of where AI is and what its limitations are. Now, getting back to the point at hand, there are a lot of companies working in the AI space, a lot of applications that we can talk about. We're going to confine ourselves to spine, and on the list of things that go on in AI, everything from appropriate use criteria through processing of reports in multiple different formats, as well as processing follow-up recommendations. We're going to concentrate our talk today on segmentation, quantification, and scan-related techniques for dose reduction automated acquisition and scan time reduction. So one of the things that really stands out in terms of AI and spine imaging that we have today and from every vendor is automated scan acquisitions. And these automated scan acquisitions can be as complex as adjusting the slice angulation automatically on a CT scanner or on an MR scanner, actually labeling the vertebral bodies, doing the actual scan, adjusting for the obliquity of the spine, doing auto coverage, auto labeling, and even curved planar reformation scouts. These auto align tools are essentially ubiquitous in the industry with a variety of penetration in different vendors, but they essentially adjust to patient position and make the images look almost perfect. Here you see a typical interface off of the Siemens scanner where the scanner has already labeled the vertebral bodies and done the appropriate approach based on the actual facility preferences. You can see that looking at some of the Siemens data coming out of St. Michael's Hospital in Toronto, they were able to substantially reduce the number of rescans and reduce the amount of user interaction. And this turned into a faster, better scan experience. At our shop, we actually had the unusual circumstance of having the same scanner with the same radiologist and the same protocols, but the only difference between two of these era machines was one had the automatic scan prescription and one didn't. And you can see there was a statistically significant difference in the average time the patient spent on the table when we had the automatic scanning tool compared to the one we didn't. So this is really a powerful tool. And as you probably already know, these tools also do automatic stitching, which really does facilitate communication. And it also facilitates reading. When I'm looking at a limited field of view, I'm constantly coming back and saying, was that a T12 or T11? T12 or T11? Having these overviews really do help and reduce my scan time. Now, probably one of the most impactful things that are available today, again, from all vendors, is the ability to do a CT acquisition, typically isotropic, but have the images come out orthogonalized in two planes to the disc space. And here you see that was a Siemens interface. This is a GE interface. You can see from the way the slides are propagating, the lines are propagating, we're adjusting to the angulation of the vertebral body. Now, how well does it work? Well, here's a fairly scoliotic patient. You can see the automatic labeling on the left, but you can really see the challenge you have at hand. In this particular case, for brevity, I've actually selected individual cuts, but you can see on the left-hand side, despite the severe scoliosis we have going on here, we've done a pretty reasonable job approximating orthogonalized imaging. Here you see another example how human intervention is important. The tech actually assesses the quality of those lines. If the tech says, okay, they push the button, then the images just come out orthogonalized to the disc space in two different planes. And here we haven't selected any of the images. This is just as they come off the scanner. And as you can see, they really have done a remarkable job, even in this severely scoliotic patient. Again, this is what the tech gets to see. They approve it, and then they go ahead and give it to run. This is from actually, this is another example of what routine clinical work looks like with the axials orthogonalized to the disc space in this patient with metastatic disease. Now, we actually did an abstract presented at this very meeting a few years back, looking at the value of these orthogonalizing tools. We called it automated adaptive multiplane multi-angle oblique. But our particular study showed that we did a better job assessing the canal dimensions when we had the orthogonalized images than we did with the typical isotropic images, which go top to bottom and don't adjust for the spine angulation. There are also other AI-driven bone reading tools which do wonderful things like, again, label the vertebral bodies, but also label the ribs and display the ribs in a way that's easy to see. How much easier? This is a patient with lung cancer. None of these rib metastases were actually called on the routine axial images because of all the challenge about reading oblique structures like the ribs. But as you can see, when you lay it out, it's very easy to see these metastases. And again, it's not a static image. You can actually rotate it and look at all different planes. You can actually get curved planar obliques or radial obliques through the rib. Here you see the lytic lesion changing the appearance of the medullary bone. All right, what else can we talk about? Well, my favorite topic is to talk about image reconstruction. AI really starts with compressed sensing, where they do this very creative, very sophisticated undersampling of case space, giving massive acceleration. And this represents an advance over traditional parallel imaging. In fact, there's very clever ways of undersampling that reduce artifact and maintain the speed. Here you see the typical examples coming off one of our Philips scanners in this particular case, giving us a routine general 30% boost in speed with maintenance or superior quality as we go along. You can actually see what some of our facilities looked like before we had compressed sensing. This was the cumulative scan time. And you can see how our cumulative scan times have been brought down to a very reasonable number with simple compressed sensing with this type of percentage gain over time. Now, anytime you have this kind of accelerator, you can do different things with it, right? You can go for really fast, say a 6-minute scan. You can boost the routine quality a bit in about 7.5 minutes, or you can start to go to higher spatial resolutions, dream a little bit bigger, and spend a little more scan time. But in terms of routine day-to-day work, this was our old scan at 19 minutes on the top. This was our new scan at 13, just under 14 minutes on the bottom, with 28% reduction in time with the exact same image quality. Here you can see a typical 5-sequence lumbar spine done in about 11 minutes and sliding through the data. You can see the coverage isn't limited and the quality is just what you'd expect. And that really is a theme for a lot of these accelerating techniques, including compressed sensing. Now, by the way, compressed sensing can really bail you out in some of these exams, usually blow up your entire schedule. Here's the traditional approach, the compressed sensing approach, identical image quality in about half the time. Here you see another example of brachial plexus, which can really blow up your schedule. You can see the scan times are very, very reasonable for this particular approach. And here you see just some routine image quality with limited volume overlapping NIPS going through the brachial plexus neurostructures. Here you see a lumbar plexus. This is the kind of thing I would hope somebody else would read in my day-to-day work. If I didn't get lucky, I had to read it myself. All right, what else can we talk about? Well, anytime you want to accelerate, you can use the typical techniques like conventional noise reduction. And every vendor's got conventional noise reduction on board. And we do use this to get some acceleration, but there are limits to how far you can go. But you can see we took this noisy image, made it less noisy, giving us the ability to do fewer necks and a faster scan time overall. Now, we're familiar with iterative reconstruction from CT, but we actually have iterative reconstruction from MR and from certain vendors. And this company called Medic Vision actually markets this iterative reconstruction tool around the world. And we did a clinical trial looking at 1.5T, and they showed that they could use iterative reconstruction, just like in CT, which reduces dose, here to reduce scan time from 128 to 49 seconds, from 249 to 90 seconds, from 106 to 35 seconds in this particular case. And again, the image quality looks about the same on superficial inspection. In our trial with a Likert rating, 3 being roughly equivalent, 3 being equivalent, you can see that we ended up equivalent between the accelerated images and the standard images, which is really what you're after, non-inferiority. Same thing in the cervical spine, 250, 155 here. In the cervical spine, the same types of results, essentially no statistical difference between the accelerated scans and the process scans. So a very viable technique. Now, we know iterative reconstruction from CT, and it allows us to use much lower doses, but get image quality that had the noise levels that we associated with high dose studies. But we also know that there are well-known limitations to iterative reconstruction CT. And the good news is we now have deep learning-based image reconstruction tools from a number of different companies. Here you see, this is what GE shows for their true fidelity reconstruction, where they essentially have this ground truth, and then they take the low dose data, compare it to the ground truth on the high dose data, and do sort of a Bayesian back propagation iterative reconstruction to get to the point where you get a low noise image that emulates our traditional image quality. You can see here what a typical filter back projection looks like with the lower doses we're using today, not so great. When we add traditional iterative reconstruction, the texture changes, still not so great. With deep learning reconstruction, we can get back to the look of the images we had when our grandparents operated the CT scanners and didn't care about dose. Here you can see the actual dose performance. If you look at this particular example, we have a filter back projection, CTTI of 80. The noise levels on CT are measured by the standard deviation, so a low noise level of 15.2. If we go to a 10% of that dose, notice the noise level goes up to 32.4. If we use iterative reconstruction, ACER in this particular case, we can bring that noise level down to 21. But if we use deep learning-based image reconstruction, we can get that noise level down to just where it was before and really give an image that looks very similar to the routine image. You can actually see, quantitatively what the noise reduction capability is, and it really does go way beyond the traditional iterative reconstruction technique in terms of noise reduction. Here you see an example with a filter back projection, a lot of that noisy salt and pepper look that comes, which we're accustomed to seeing in CT. When we go to the ACER type iterative reconstruction, the image texture changes, but it does give you a lower noise image. But when we get to the deep learning image reconstruction, this is very reminiscent of what we had before when we used very, very high doses for CT of the head. And more importantly, it is not just noise reduction, it actually is improvement in contrast to noise. Again, you can see where we were in filtered back projection and where we are with some of these deep learning techniques. Pretty impressive. Perhaps even more importantly is the way the behavior of deep learning image reconstruction differs from the traditional iterative reconstruction. As you can see, if we look at multiple materials, there's a really nice collinearity when you use filtered back projection that dies when you use iterative reconstruction of traditional techniques where you use ASER or typical model-based iterative reconstruction. It's not the same. We all know this, that things change. We know that with traditional iterative reconstruction, the Hounsfield unit numbers change. The good news is with deep learning, they don't. Things look exactly the same. The numbers are preserved, and that's a big advantage of deep learning. Here you can see what also happens to image texture. You can see here in this particular case, when we process an image with ASER or ASER-V, which is a hybrid model-based iterative reconstruction, there's an odd texture to the image that we don't have when we do a deep learning image reconstruction in this case. Now, you can actually measure this in something called the noise power spectrum. Notice that the blue would be the filtered back projection. The orange is what we get with deep learning. And notice there's a strong collinearity of these curves. But notice the enormous difference we get with traditional image reconstruction, in this case ASER, where there's a major shift in the noise power spectrum. And that's a quantitative way of saying the texture changes. Here you can see a head phantom. This is what a filtered back looks like. Notice the striking difference in texture when we go to the ASER-V example, where it's much more coarse and more modeled. And notice how very similar the deep learning reconstruction looks to the filtered back projection here. So a big advance. Now you can actually also look at this by subtracting, seeing what we're losing. Now, if we take this phantom and super process it and subtract the two of them, you can see we've lost a lot of structure. But notice when we take the same phantom and we process it with deep learning image reconstruction, there's no structure missing. So it's really well preserved. You can see that in this head study. This is a really low dose study. This is what it looks like when you process it with deep learning. Subtract the two, you see no structure, and that really is quite reassuring. And just a couple of examples, not the best examples, showing you how spine images look with deep learning image reconstruction. They don't strike you because they look like normal images. Here you can see the traditional iterative reconstruction on top, the deep learning image reconstruction on the bottom. You can see the difference in noise performance, and you really don't see anything unusual because they look like routine day-to-day images, which is really, one of the really holy grails. Now, I don't have much time left, just to mention that Canon has a tool for this, and Clarify has a tool for this. So a lot of people are playing in this space. Now, we don't have much time. We're probably going to end up stopping after the image reconstruction piece here because I'm out of time, but I want to talk to you about something I'm really excited about, and that is deep learning MR image reconstruction for MR, obviously. And there are a number of different companies that have tools. GE, Canon, and Siemens now have tools released for their systems. And one company, Subtle MR, has an agnostic tool which can work on anyone's system. And here you can actually see an example of what we got with a noisy image. The traditional system, noise reduction, does a nice job. But look at how much better it looks when we look at deep learning image reconstruction. Now, to me, this has got a higher curve appeal, but maybe you're not impressed. How about this one? When we take the slice down to a really, really thin slice and get this type of noise, you see the system noise reduction can't get there. Yet look at this image, sub-millimeter 2D fastband echo. Look at that image quality. And that is a big difference. Now, the other things that these deep learning tools can do is they can learn to recognize artifacts like truncation. Now, we traditionally put apodization filters or Fermi filters on our images to reduce truncation. When we turn that filter off, the truncation comes back. It almost looks like there are multiple lamellations, like a slice of mozzarella in the cord that are in here that aren't real. Now, if we can train the algorithm to recognize this, we can leave the filter off and let the algorithm do the job. Why do we want to turn the filter off? Because the filter works by truncating the edges of K-space, tossing out spatial resolution. Turning off that filter, accomplishing the artifact reduction through deep learning, allows the resolution to rise. Here you see an example where I've turned off the filter, and you can see there's truncation in the image, and then I've allowed the deep learning reconstruction to process that image. Same data, much better looking. Same thing here, without the filter on with traditional reconstruction, without the filter on with deep learning reconstruction, much, much sharper. And if you take a closer look, you'll notice how small the spinal cord looks compared to this conventional reconstruction that we see here. Now, you can see how formidably powerful this tool is. This is what was coming off the scanner that day in 2 minutes. This is what the tool will deliver in 1 minute. Pretty impressive. Now, if you look across the board, this is what we're able to deliver. Our old scan was 2 minutes long. The new scan is 1 minute long, but when it's not processed, it looks like this, but processed, it looks like this. Same thing here. This image, it takes 132 compared to the gold standard right here at 254. Here's a stir, always a challenge. Notice how clean and crisp and sharp these images are, much better than the source image that this was made from. And you see the same type of image information in the axial plane. So, I'm out of time here, and rather than showing you the rest of my material, I'll be respectful of the rest of the program and stop here. Thank you for your attention. I would have loved to show you some of our research in this space and some of the other developments in spine AI, but 20 minutes is just so much time. Thank you very much for your attention.